All right, let's get started. This is Rush University Medical Center, Division of Nephrology, Renal Biopsy Conference for August 3rd, 2023. We do not have a CME code today. We should have it at the next conference. This conference is being recorded. As usual, we have nothing to declare. And for privacy, we are maintain patient privacy by changing identifying information, ethnicity, dates, exact laboratory values, etc., to disguise the identity and protect their confidentiality. This is a case of mine. It's a interesting case. I think it'll bring on some very interesting discussion. So without further ado, I will read the protocol. The patient is a 60-year-old white man who noted acute onset of swelling 3 to 4 weeks prior to seeking any medical care. He went to his PCP, who found hypertension at 180 over 110. This was new, and he was told to go to the ED. He did not have a prior history of hypertension. In the emergency room, his BUN and creatinine were 25 and 1.6. His hemoglobin was 12.5. His white count was 12,000. His platelet count was 290,000. Those were both normal. The UA showed 5 to 10 red blood cells, 21 to 50 white blood cells. There were granular casts present. They didn't give any number. It's just they said there were granular casts present. And on dipstick, there was large blood and greater than 300 protein. That's a dipstick estimation. The urine protein creatinine ratio was done. It was 7.8 grams per gram. The rest of the CMP was remarkable for a serum albumin of 1.8 gram per deciliter. His calcium was 7.9. They ordered a number of serologic tests in the ER. COVID-19 was negative. A C3 and C4 were normal. ANA double-stranded DNA were negative. Serum immunofixations showed no monoclonal spike. Serum kappa lambda free light chain ratio was normal at 1.13. He was told his kidney function was normal 6 months ago. I don't know if that was urinalysis, creatinine, or what, but that's what he knew. He had not had any recent dental work. He was told to see a nephrologist ASAP, and he actually got an appointment in a few days, who saw him and scheduled a renal biopsy for the next week. But it was delayed because he'd been taking some aspirin, baby aspirin, kind of prophylactically. Because he felt so poorly over the next few days, many days, he had no energy, no appetite, and it got to the point where he wasn't even getting out of bed. His wife brought him back to the emergency room, now 17 days after original presentation. And now his BUN and creatinine were 130 and 20. His serum albumin was the same at 1.8. His hemoglobin was 10.5. Platelets are still 500,000. And white count a little elevated at 14. His urinalysis was really unchanged. His urine protein creatinine ratio is now 5 grams per gram. They added a hepatitis C antibody and hepatitis B surface antigen were negative. They did a number of serologic tests, were also repeated, and there was no change. On review of systems, really nothing besides fatigue. He had loss of appetite, edema, no shortness of breath, orthopnea, hemoptysis, rash, arthralgias, sore throat, bone pain, gross hematuria, recent upper respiratory tract or other infection, no fever, chills, or weight loss. Past medical history is not diabetic or hypertensive. He had a thoracic aortic aneurysm that was found incidentally several years ago. Really no past surgical history and no family history of any renal disease. He was a former smoker, occasional drinker. He took lisinopril, but that was only started recently in the emergency room. He took Indocin, but hasn't taken it for quite a while. There was no known drug allergies. He was ill appearing. Blood pressure was 140 over 70. Weight was 106 kilograms. It was 102 just 2 months prior. His BMI was 33.6. Temperature 97.6. Heart rate 88. He was alert. Mouth, neck, lungs are normal. Abdomen soft, non-tender. Cardiac exam had no rub or murmur or extra heart tones. His extremities had 3+ edema, but there was no rash. On laboratory exam, his sodium was 134. His potassium 3.8. His chloride 111. His bicarb was 14. His BUN was 130. His creatinine was 20. His albumin was 1.8. Total protein 6.5. His globulin was 4.7, slightly elevated. Gamma gap there, normal is 4.5. His calcium was 8.4. His LFTs were normal. His blood glucose was 100, and he was COVID negative, as I mentioned. His white count was 14.1 with a normal differential. Hemoglobin 10.5, platelets 510,000. Urine specific gravity 1020. Glucose was negative. Protein was greater than 300. He had large blood on dipstick. 6 to 10 WBCs, and now they just tell us greater than 10 RBCs. So I don't know if that's 11 or 111. And again, another urinalysis which said granular casts, quote, present, but nothing quantified. Urine protein creatinine ratio now 5 grams per gram. He had an ANA, anti-double-stranded DNA, hepatitis B surface antigen, hepatitis C antibody, ANCA MPO PR3, serum immunofixation, serum free light chains, kappa lambda ratio, serum free light chain kappa lambda ratio is normal, C3, C4, all these were normal, negative or normal. Blood cultures were not done. Cryoglobulins were sent off locally. An anti-GBM antibody was sent off to Mayo and was pending at the time of the biopsy. Chest X-ray had no infiltrates. The renal ultrasound showed normal-sized kidneys without evidence of obstruction. Dialysis was initiated, and a percutaneous renal biopsy was done under CT guidance. Any questions? All right, let's get to poll number 1. What do you think is responsible for this patient's AKI? Number 1 is crescentic IgA. 2 is an ANCA-negative vasculitis. 3, an infection-related GN. 4, ATN alone. 5, a paraprotein-related renal disease. Or 6, anti-GBM disease.
Give me a second here. One of the poll. While you're thinking, give me 1 second here. For some reason, one of the options did not get in there. I'll launch the poll while I fix that. So you should be able to see the poll now.
Yeah, if they don't all show, pull the poll down. So crescentic IgA, ANCA-negative vasculitis, ATN alone, a paraprotein-related renal disease, or anti-GBM disease. We just got done with the board review course, and there's two type of we have a lot of audience response questions. There's two type of questions. One where everybody gets it right, and one where there's a big mixture. I always think that the better the mixture of answers is, the better the question is, and the better people are going to learn from it. So I wonder if they're swayed by the fact that we waited so long to add crescentic IgA. They figured, well, if they insisted on being it there, maybe it's got to be crescentic IgA. It's still a good answer.
That way.
It's a good answer. I'm just saying.
All right.
2 more people. Okay, that's enough.
Yeah.
So nobody bought infection-related GN. How interesting. So we've got about half of the people. The majority think it's crescentic IgA. That's the biggest number. And then there's the second was an infection is ANCA-negative vasculitis, and then a few with ATN, paraprotein, and anti-GBM disease. Next slide. All right, so Bill, I want to hand it over to you. Tell us what you think of these diagnoses.
I think this is a really tough case because I'm glad to see that there was a big spread here because it doesn't really fit into one pattern clinically. There's features there's nephrotic syndrome present. There's significant AKI present. There's significant hematuria and hypertension and what looks like a nephritic syndrome. So you've really got all the possibilities of all the glomerular diseases in this differential diagnosis. So you kind of got to lean on which one you think is the most predominant when you're developing your differential. And clearly, the patient needs a kidney biopsy. And speaking quickly about the need for kidney biopsy, since the patient was on aspirin and the kidney biopsy was deferred, I think it's fine, if not even wise, to do so for an elective procedure. And we didn't really know if this was elective or not, because at the time the patient's creatinine was 1.6, and I don't think you really knew that they were going to take off like this. But certainly in an emergent situation, you do not pause and wait for the aspirin effect to wear off. If it is elective, we typically hold the aspirin and we'll do the biopsy, but there's plenty of studies out there that have done biopsies in patients on aspirin and have not had bad bleeding outcomes, even though we know that aspirin does impair your bleeding time and your platelet function analysis time as well. But back to the case, I think when I have this much of a crossover of a nephritic and a nephrotic, I usually think about like a collapsing FSGS, where you can have nephrotic and AKI and sometimes have hematuria. I think that's going to be on the differential. An MPGN pattern of injury often can be nephrotic. You know, I think 10 to 20% of patients with MPGN pattern, depending on what the cause is, can have nephrotic syndrome as well as AKI. So I think there's nothing really that points to any cause of an MPGN pattern of injury here, except for the fact that he had really significant hypertension when he presented, and maybe a TMA type picture chronically could lead to nephrosis, and that'd be a immunofluorescence negative MPGN pattern. Could he have a paraprotein related GN, which can give you somewhat of a crossover? It can give you AKI if you had like myeloma and cast nephropathy, and if you had underlying amyloid, that might be responsible for the degree of albuminuria. I think that's possible, but again, the hematuria would not be as predominant. And here I think hematuria is really predominant too. And I don't think about hematuria being as predominant in the MPGN patterns necessarily, or in the collapsing FSGS. So it's a really tough case, I think. You know, if you think about crescentic IgA, you wouldn't expect this much proteinuria. If you think about ANCA-negative vasculitis, you wouldn't expect this much proteinuria. And I've heard Ron Falk say that there is no such thing as an ANCA-negative vasculitis. If you have one, it's just that the ANCA wasn't done correctly. Now he can say that, not me. So I think this is a really tough case, and the patient really needs a renal biopsy. The rest of them, ATN alone, no, I really don't expect that. I think we're gonna have a glomerular disease here. We have too much proteinuria, too much hematuria to think about ATN alone. And I didn't really touch on anti-GBM disease, I guess, which is always possible. And we have the little teaser there that the antibody was still pending. There doesn't have to be lung involvement, and you know, you can have renal limited anti-GBM disease. But again, I don't know offhand if they present with this degree of proteinuria, edema, and hypoalbuminemia. So it's a tough case. So in most of my crossovers, I usually pick a collapsing FSGS or an MPGN pattern. So I'll stick with those two, but really a broad differential here.
So, I mean, if you look at the poll options, obviously I'm pointing towards a nephritic syndrome here. It's interesting how much people focused on the proteinuria. And I don't know the answer. I mean, when there's this much acute renal failure, I don't know how reliable all those things are. But I guess if you look at the fact that what he presented with was edema and a low albumin, I mean, how can you argue with that? I think that was Steve's point originally.
Yeah, nephrotic range proteinuria, I'm not usually putting that much stock on, but if you have nephrotic range proteinuria in the setting of a low albumin with edema, you know, I mean, we don't have a cholesterol, but it's hard to ignore that and not think that there's one of the nephrotic GNs here.
I mean, then, you know, then the poll's going to have like 5 more things. It's going to have MPGN, yeah. It's going to have collapsing GN, and, you know,
minimal change with ATN. I mean, there's a lot of things.
No, I think
like
that's pretty
again,
funny.
Again,
I'm almost glad I didn't think about that much, because then we would have had Prepared still be putting things in the poll.
Still blames him.
He still be adding options in the poll. Any other thoughts, anybody? Dick, what do you think's going on?
Well, I pretty much agree with Bill. I think the overall clinical presentation is not typical of any specific cause of AKI, other than the fact that crescentic forms of disease would be high up on your list. I can comment about anti-GBM disease. Less than 5% of patients presenting with RPGN who have anti-GBM will have nephrotic syndrome at the same time. So that downgrades the likelihood of anti-GBM, but it cannot be excluded based on clinical grounds. And second, to have IgA nephropathy in a crescentic form without any prior history of recurrent bouts of hematuria would be highly exceptional. And I downgraded IgA nephropathy as a potential cause. I think this is nephritis and nephrosis, probably with superimposed crescents. Now, the aortic aneurysm is kind of an interesting thing here. Most aortic aneurysms in the thoracic cage are non-atherosclerotic. I suppose a few of them could be atherosclerotic, and this might be atheroembolic disease, spontaneous. It's a rare disease nowadays. We almost never see it. I haven't seen a case in 4 or 5 years, but syphilis and congenital abnormalities of the collagen system are the 2 most common causes of aortic aneurysm, and of course, hypertension of longstanding.
So when
I don't
saw-
think that has much to do with this disease. I was thinking it might be infected, and we missed it somehow, and that this was an infective form of endocarditis with manifesting as an aneurysmal dilatation of the aorta. But no murmurs and no other findings. I don't think it's likely.
Fair enough. Well, that's actually, you know, where I didn't think about atherosclerotic disease, but I was wondering about a possible infection, an infectious related GN, and that's the behind the poll, adding that to the poll. In spite of the serologies, which are quite variable in infectious related GN, you know, they're not always low C3 and everything. So, Dr. Corbett, well, Bill, what is your number one diagnosis? Did I miss it? Yeah, I didn't miss it.
I said I usually end up having to put my nickel in these crossovers on a collapsing FSGS or some sort of MPGN pattern of injury.
Okay,
Those are my top.
those are two things, you know.
I know that. Those are my top.
Your two favorites.
Was there-
Roger,
Yeah, Dick.
I did want to make a comment about Bill's very important observation that aspirin therapy should not be used as a contraindication or a delay of kidney biopsy in patients presenting in this fashion. I've seen a few patients in which the biopsy was delayed for more than a week simply because the patient was on aspirin and they watched the creatinine go from 2 to 10. That's not a good idea.
And in this case, the creatinine went from 2 to 20, and it was about 14 days. So,
Yeah.
a very good point. And we'll have to decide later if we think this could have made a difference or not. But it's not an irrelevant point.
Roger, was that PLA2R, a crescentic membranous that had been brought up by Dr. Reen?
I did not have a PLA2R.
No.
Yeah. And also, yeah, membranous with anti-GBM. There's a lot of anti-GBM overlap things that you could always talk about. So let's move on. Let's see who's going to read the biopsy.
While we're doing this, I wanted to bring up something Bill brought up already. You know, there's a distinction. I mean, people talk about nephrotic range proteinuria, and you'll see a lot of papers that'll talk about nephrotic range proteinuria, and then there's nephrotic syndrome. I mean, nephrotic range proteinuria is when you've got more than 3.5 grams of proteinuria, but you aren't necessarily hypoalbuminemic or edematous. Nephrotic syndrome is exactly what this person has.
Yeah.
He's got nephrotic range proteinuria for sure, but he's also hypoalbuminic and edematous. So you'll find papers that talk about what percent of patients had nephrotic range proteinuria, and then another group within that same group of which ones were truly nephrotic syndrome. So one just refers to a protein level without necessarily having hypoalbuminemia or edema. The other obviously includes all three.
All right, thank you.
Roger, let me comment about Dr. Reen's suggestion for an anti-PLA2R. Membranous nephropathy can be combined with anti-GBM disease.
Hmm.
That's very well recognized. And I suppose that in this patient who presented first with nephrotic syndrome and edema, and then developed a very rapidly evolving disease, should be considered as having anti-GBM antibody disease secondary to anti-PLA2R membranous. I think that's a good point.
Does anybody not think this guy could have taken NSAIDs somewhere along the line and gotten nephrotic and then had acute interstitial nephritis and ATN?
Could be.
I was kind of waiting for somebody to
be.
say that, because that was coming. I know it says he'd had Indocin and wasn't taking it for a while, but I remember years ago I had a patient come in the hospital, was completely shut down, and it turned out he'd been on ibuprofen for weeks before, and he just never really talked about it much. And then when the biopsy came back, Mel calls me. He's like, he's got diffuse effacement and he's got interstitial nephritis.
Good
Yeah.
point. Yeah. Well, obviously, the differential just keeps growing. I'm gonna spin the wheel before we have 5 more things to add from the text box. Dr. Baxi.
All right.
Fellows are
I think it's
spared.
I think it's leaning over to Saba there.
I don't.
Saba disagrees.
Somebody disagrees, and the wheel, you don't question the wheel.
You don't question the wheel. So let's go ahead. And we actually had a case of crescentic membranous with ANCA negative and anti-GBM negative. So I wonder if that's what it'll be. So low power, very low power, not the best image here. This looks like a PAS. I don't think we have David here today, right? So you're David today, Roger?
Oh yeah, I'm sorry. David's gone. I am David.
Okay.
This is an outside case, and I invited our outside pathologist, but she couldn't make it. So I'm David.
All right. So we definitely have a few gloms. I can't really make out much in terms of the glomerular structure at this power. In terms of interstitium, I mean TIN I saw was on the differential. It's just too much. I don't see patches of cells, but we'll have to comment on a higher power. This doesn't really give me too much information on the glomerular. This one, there looks like definitely this is the tough and might be a crescent around there, but let's go to the next slide. Sure enough,
I think, Pravira, one thing to comment on, if you go back, in any antiphospholipid antibody syndrome, since that was on the differential, sometimes you have at this low power, you may see a striated pattern where you're having part ischemia of one whole section and then part regular, and we don't see that here. It doesn't rule it out, but it's certainly, I think, something to mention. You'll see a whole section of just ischemic looking tissue, and then the whole section right next to it could appear normal.
yeah.
We don't have as many slides as we usually do, and we kind of got what we got, but there'll be plenty. Just FYI.
Yeah, and we can't really comment on chronicity either, but sounds like he had a pretty normal kidney function from what he was told. So this is another high power one glomerulus right here, and you can kind of see you could kind of make out if that's the same glom. This is a PAS stain. Is you have a circumferential crescent that's quite bad, and the tuft has kind of been compromised to just here. So, I mean, this is really circumferential crescent. In terms of interstitial, you can maybe see some increased cells, probably just related to the inflammation from this glomerulus. Can't really see much of, let's see, I mean, maybe some ATN. This brush border looks okay. Maybe some ATN over here, but the biggest glaring thing is a kind of circumferential crescent. You have a blood vessel over here, which we'll see if we have more images of that. Another PAS stain, high power one glomerulus, looks like a PAS stain. Looks like, again, there is, this looks like a crescent here. This almost seems, it's hard to tell, but not fully circumferential, because I think part of the glomerulus is hanging out here. So, but you can definitely see here, this looks like another cellular crescent with a tuft kind of, again, squished in here. Anything else, Roger? I'm not seeing anything else on this one at least.
That's.
I mean,
there's
not
very
much.
little
There-
there.
Are there a
very
couple
limited.
polys in there?
Let's see.
Yeah, that's
Yeah,
good-
maybe
good.
right here. Yeah,
Good case. Yeah, looks like
Yeah.
there's very little tuft left, very little
yeah.
glomerulus left.
Looks like maybe a multi-nucleated cell
Yeah.
there. I don't see any other, but yeah, I mean, again, part of this, you can see Bowman's capsule has been kind of ripped off here, just the sample, so we don't have the full glomerulus on this slide. Another glomerulus on the screen here. This also looks like a PAS stain. Here it looks like kind of just, is this, I mean, this looks like kerrectic debris, maybe fibrinoid necrosis here.
Yeah, I think that's kerrectic debris.
Yeah,
Actually,
kerrectic
throughout.
debris. There's not a cell, there's not a crescent here, but there's still active inflammation of, likely it would be fibrinoid necrosis. Not the best cut. It looks like you know, you don't see a lot of open loop. I mean, you have some
It
open.
looks
loops
like it's on
here.
its way out.
Yeah, it doesn't look like there's much left, and not much else you can really see, but that looks like maybe some kerrectic debris.
The
If
mesangium
arterial-
looks, the mesangium looks expanded, but I don't know, as Steve pointed out, that's just an artifact of it going, which he's shaking his head, it's just an artifact of it becoming a sclerotic glomerulus.
Mhm.
Yeah, okay.
Looks like an arterial here. That
I'm
looks-
David with Steve's help.
Yeah.
Sorry.
No, I'm serious.
Yeah, the vessel doesn't look normal. There's not a lot of hyalinosis, but
No.
there was another blood vessel. There was an artery on the first biopsy.
We're gonna
on
show a big
first-
picture of that.
Oh, there's a big picture coming up. Okay. But yeah, this, I mean, definitely does not look normal, but I don't see any, clots in it. It just looks like there may be,
It's narrowed.
yeah, a little hyalinosis.
I see again. I see more polys again. There's one at like 7 o'clock outside of the glomerulus, right down below.
Oh, right here. Yeah.
Yeah, right here. And then there's one up top, like maybe 10, 11 o'clock. Like I don't know where it is. It's
Right there.
Yeah,
right
there's
there.
one.
There's one like right to the 3 o'clock of the glomerulus again in that space. That so there are all these scattered
Here's another one, maybe,
multinucleated cells.
potentially.
Yeah, there.
But Casey, what is that? You've brought it up twice. What are the polys?
Just the idea of like infection related or post-infectious or I suppose urine culture was negative, so pyelonephritis is not. I mean, I don't see an interstitial infiltrate, but you see polys. You have to think about like some kind of a infection related process.
Mhm.
Yeah, I don't think they're limited to that though, but clearly, I mean, that's what you'd think of first. But we've seen a lot of bad inflammatory GNs with a lot of
Mhm.
polys in them, and he had pyuria, which kind of also fits. Maybe that's part of this whole pattern.
You have a silver stain here, which kind of nice. I mean, it looks like it's the same slide. Almost. Let me see. Yeah.
It is.
Yeah, it's the same slide, just a silver stain. You can see again, this part of this, we don't see any breaks or anything like that in this one glomerulus, but you do see what we look like, in the mesangium kind of expansion, but not much else you can kind of tell from this one glomerulus here. But what you do see nicely here is this arteriole, and then you see, it looks like an RBC cast over here.
Nice.
Even the one down, even the glom, if you look at the left corner, it's
Mhm.
almost like a double contour there. You can see there's a
Yeah.
and then there's mesangium interposing.
Yeah, so it's kind of on its way out, kind of.
Yeah, it is. It's hard to make much out of it because it's all squished down, but it does kind of suggest that there's like an MPGN-like pattern there.
Yeah, something chronically going on here. We can see, I don't know, that's a little protein resorption droplets over here, but about it. I mean, you can't say a lot of, at least you have an RBC cast, but other than that, I don't.
I guess it doesn't like what we're saying.
Now it's recording.
Next
data.
slide.
Yeah.
We
here
have
you go.
another PAS, and this is, I guess, what Roger, you're alluding to is a
Oh.
big vessel here, artery.
That's kind of scary.
Yeah,
Yeah.
hope they weren't on aspirin.
Yeah, good.
Good they held the aspirin. But we've seen crescentic lesions, and sometimes you can get arteritis. I don't see any. I mean, I don't know if this is, maybe that's just, I don't think
This is
there's any.
described as arterial intimal
Oops.
fibrosis.
Yeah, this
Okay.
is bad hypertension.
and
Yeah,
mild arterial
hypertensive
hyalinosis,
disease.
but not arteritis.
Arteritis.
Yeah.
Okay. I mean, it's definitely narrowed. You can see the lumen's
Yeah,
quite
anything
narrowed.
a little
So
bit,
that, along with arteriolar hyalinosis, kind of goes along with kind of chronic hypertension. You have some tubules here that this one looks kind of thinned, so maybe some ATN. But the biggest thing here is some arterial sclerosis. Immunofluorescence, this is important. So IgG is positive. On our differential, we had IgA, ankle vasculitis. So this kind of does not go along with any of those, but this is IgG.
Where do you see it?
It's primarily in the capillary walls. Kind of see deposits kind of all along. It does not look like granular like you would see in membranous.
I don't know. There's pretty big humps.
Yeah,
but-
almost like, what, yeah. So, I mean, infection related, it could be seen in infection.
But it's a lot more than just a few big humps. I mean, there's a
Yeah.
lot. If you look at the capillary
Here
walls,
too.
you see them are granular deposits along the walls as well.
Would you say it's granular? I mean, I guess some areas are granular.
Yeah, right where you're pointing, those are granular.
It's
But
not
these
linear.
look like they would be more subendothelial.
Well,
Here
we'll see the EM, I guess, right?
Yeah,
That's
I mean,
I think that's the vascular pole there, but
maybe some, and I guess we'll see. But here that kind of look like almost a big deposit right here. So IgG positive and maybe slightly granular, but definitely throughout and mostly in the capillary walls, not much in the mesangium. Kappa, so paraprotein related lesion was also on our differential. Kappa is positive, so we want to see if there's any light chain restriction, where there's not. So kappa and lambda are both equally positive, it appears.
but go back to the lambda. I mean, you look at the capillary walls in the lambda, you could see granularity along the capillary walls there with
Maybe a little here.
Yeah.
Yeah.
Hmm.
I wonder.
I don't know. I mean, you could even see it here then too. I don't know if that's right here too. You could say maybe that's granular, but they're equally deposited. I don't know if we have C3 or any of the other stains.
But you would think with infection, their C3 should have been positive.
Yeah.
C3 was 3+. I don't have it.
Okay, so C3.
IgG 3+, C3 3+, kappa and lambda 3+.
Okay,
Other stains are negative.
okay.
So I don't have that picture, but C3 was positive. So what I don't have is a low power of the EM, so it's a little tough to orient. Good luck.
Can I ask the fellow? So we have EM. Yeah, orientation is going to be difficult here. Oh my God. Let's see if I can see any. This is really tough, actually. Give me a second. Look for. I don't even see RBC.
I think this is subendothelial here, but I'm not sure. It could be
Trying to even
mesangial.
see like a slit diaphragm. Maybe is that slit diaphragm right there? Maybe.
Yeah, I think
Oh, is that so? That maybe be endothelial, and this is
I think you're looking at the GBM, to be honest
Yeah.
with you.
the
yeah.
GBM,
Not
I
there,
think
but
is in the middle.
Right in the
That's-
middle.
There. I
look
mean, you can
there.
definitely see
Yeah.
there's deposits there. I mean, you can see, and these to me look like they're fibrils, which we'll see at a higher power. I mean, these
Yeah, you get a kind
They
of
look
sense
like-
of that.
they look like, you know, they definitely are deposits, and it's not. It's something we're gonna have to see at high power, and that's within the basement membrane. It's just hard to orient, which is where is where. Let's go to the next slide. Doesn't make it any easier, but
Well, that's a
there's podocyte right
there.
there, right? That's the podocytes. So this is sub epithelial.
No, that's basement membrane.
Is that basement membrane? I mean,
Yeah.
Subendothelial.
subendothelial.
I think it's.
Oh, I'm sorry. Yep. There's okay. Okay, fine. Yeah.
They look
smoke-
organized there.
Yeah. Yeah. Organized. They do look organized.
Mhm.
Organized deposits.
Similar.
Still very hard to orient. I don't know. I
just-
felt like that first one looked very fibril-ish.
This does
Um,
too.
Yeah, and this one is kind of hard to tell, but this looks very fibril-ish right here.
Well, there you go.
Yeah. Don't have a measure, but definitely looks deposits are organized and made up of what looks to me as fibrils.
And they're randomly oriented.
Yep,
So-
randomly ordered.
Right, yeah, good point. So we have 16 glomeruli were present, 14 of 15. One was sclerotic, 14 of 15 of the remaining glomeruli had cellular crescents. They were all circumferential crescents, as Priya pointed out. Only 10 to 20% tubular atrophy. The vessels, as we saw, showed some intimal fibrosis and mild hyalinosis, but no arteritis. The Congo red was negative. Next slide.
That's helpful.
So I want to poll you guys now. What do you want to do now? What more do you want? Do you want pronase digestion for or IF staining? Do you want fibril size determination? Do you want a bone marrow biopsy? Do you want the results of the serum anti-GBM antibody and the cryoglobulins, both which were pending at the time of the diagnosis? Or do you want something else? You could put your something else in the chat if you want. We've got IgG subtyping. I don't have that KCDNA GB9. That's an interesting thought. Three DNA JB9s. And someone's saying fibrillary. Interesting. Okay. Well, the people that are putting in the chat box are unanimously picking a DNA JB9 test. I thought, something else to think about, I suppose, with those, funny deposits would be the thought earlier of a, PLA2R. And now someone is using the term smudgy IgG, which is a buzz term for the way immunofluorescence and these things kind of look in the disease it's being alluded to, which is fibrillary GN.
I didn't think these looked that smudgy, to be honest. They look pretty
these are
discreet.
smudgy.
Maybe
Yeah.
some areas if you kind of
Those are
hear.
pretty discreet.
Yeah, I don't know why. Okay. So
And
Sure.
pronase may unmask a light chain restriction, which is always the case. And that's the point. So, well, our poll is basically pretty much across the board. The only the lowest is a bone marrow biopsy. Fibril size is an interesting thought, pronase digestion. And I think there's something else is the 5 people that put DNA JB9 in the chat. So let's see what we have next. Drum roll. And it
Yeah,
indeed is
okay,
DNA
yeah.
JB9. So as usual, we can't fool anybody in this conference. Our audience is so smart. Which here, this shows 3 glomeruli highly lighting up for DNA JB9. And the next slide is a single glomerulus, basically showing the same pattern that we saw on immunofluorescence. And what's interesting is how much is actually in the capillary loops here. Pretty impressive. It's a combination of both, but very impressive there. So what's your diagnosis, Pravir?
This would be fibrillary GN.
Yeah, it's really
It's a
defined by that.
crescentic fibrillary GN with crescentic, I mean, with diffuse crescentic disease, 14 out of 15 with ATN.
And we'll get into that specific, which is not, that adjective is extremely important as part of this case because it's ultimately determining his clinical presentation and possibly outcome. Next slide. So this was read at Arcana. And when I asked for the slides, Dr. Boyles, who couldn't join us, said, yeah, this is a very interesting case indeed, truly a teaching case, as the deposits are largely along the capillary loops, almost appearing to have a linear positivity by IF, which is a little different than what some of the people were thinking, but I'm not about to disagree with Arcana pathologists. Then with the severe crescentic morphology on the EM, one could mistakenly diagnose anti-GBM disease. Careful searching for rare intact portions of glomeruli by light. You can see the non-agrillophilic appearance of the mesangium and along the capillary loops. The EM I thought was lovely with nice fibrillar deposits. So that's how she read it, is exactly what Pravir's diagnosis was crescentic fibrillary GN.
Pravir, next time, could you use the word lovely in your pathologic description? I think that would make it a little bit better.
Noted, duly noted.
Touche, Bill. So next slide. So back to Bill. What do you think about this case? I'm not even asking treatment. Just what do you think about it, and maybe treatment? What would you
Well, with that much glomerular involvement, you can see why there was proteinuria probably to begin with for a while, and then suddenly it takes off with, it's always been interesting to me as to what causes that set release to just go bang an AKI. In other diseases, there's a second hit or something that might set you off, like your ApoL1, at baseline, and then you get COVID, or then you get HIV, or then something like that, and it makes you take off. Parvo, for example. But it's interesting to me, he's probably had something in his glomeruli. It's not like those all suddenly came in all at once at every single glomerulus and caused this rapidly. They've probably been there a while, and at some point something tipped them over to have a break in the capillary wall, and then bam, there's crescents and AKI, and you're in trouble. And I don't know in this disease what does that. In the lungs with good pastures or something, you think about smoking or different irritants that might set you off for alveolar hemorrhage. But I think that's an interesting part here. I don't know enough about this to know if there is something that sets it off.
So what about Hickman's dictum that this could be underlying fibrillary GN, and now he has an ANCA-negative vasculitis? Big silence. You're shaking your head.
Roger,
Certainly
for
didn't
me,
think
what is interesting is that all of us were struck by the nephrotic presentation of this case. And we mentioned things like collapsing GN and combinations of membranous nephropathy and NIGM, but not one of us mentioned fibrillary glomerulonephritis. So anytime in the future that you have a differential diagnosis of rapidly progressive glomerulonephritis with a nephrotic presentation, I think we ought to include fibrillary GN in the differential diagnosis, especially when we don't have features that strongly support ANCA or anti-GBM disease.
You're right about that. The guy that used to pick that diagnosis retired about 5 years ago, but there was one person who when we used to have it in-house, and this one person, Dr. Earl Smith, every time we'd be talking about everything, and Earl out of nowhere would say, oh, that's we would call it immunotactoid glomerulopathy. And it's like, he'd be the one person to be thinking that, when the rest of us who you would have thought would be thinking about it weren't. So you're right.
The problem is he was only right once every 2 years. So
well, it's like even a blind squirrel finds an acorn every once in a while, for God's sakes.
Are the majority of these cases, do they present with a crescentic fashion, or is it only like 5%? Or
highly unusual.
Crescents and fibrillary GN are not common.
Yeah, I'll get into that in a little bit here.
Yeah, I was just say fibrillary GN, and I know you probably have, I won't get into it. You
No, it's
probably
okay.
know, but it's
Because
very
the
uncommon.
Nephrotic and the nephritic, I do understand that, but the nephrotic and nephritic plus the AKI here, I don't think that was going to be on my differential. I should add it. I need to, be more complete.
That's why I don't really know. I mean, should we be really thinking about, crescentic membranous and some of these really rare things?
Fibrillary GN is like IgA nephropathy, as far as I'm concerned. It can be anything from just mild mesangial deposits all the way up to diffuse proliferative and crescentic GN. I mean, all these lesions have been described.
Yeah. So, Praveer, can you give me control?
I thought you had
Absolutely.
control.
Go ahead, click on the screen. Go ahead.
All right. So, a little bit of background about fibrillary GN and some history that has to do with Rush, and hopefully Steve will enjoy this. But it was fibrillary GN for whatever it was representing, at least, was first described in 1977. But it was kind of always lumped with ITG immunotactoid and fibrillary GN. And this was a problem with nomenclature, really. And I think this was somewhat created by what Dr. Schwartz did in Jason in 2002 when he called them. He broke it down into the fibrillary glomerulopathies. And really what I think he was talking about is the GNs with organized deposits, not realizing that name fibrillary GN would soon become its own disease. So there's this long confusion about what is fibrillary GN. Is it where you can see here, he just breaks it down into this, as opposed to the more recent, I'll show you, breakdown would be based on where fibrillary GN is its own diagnosis down here. So I think there was a lot of confusion. So it was Schwartz and Corbett versus the world. Everybody, Steve wanted to make the point that ITG is very different than fibrillary GN. And I think they were just got caught up in their own issues, their own nomenclature. But
it was a diagnosis of exclusion. That was our big thing. Yeah.
Okay. So I just want to make the point, though, that they are very different, and this was ITG. This is Steve and Dr. Lewis and Dr. Schwartz is the first description of ITG, and you can see these kind of tubular structures, and they can be very much larger compared to fibrillary GN, which are very randomly and not often as big. So they clearly look different on EM as well as other things. So at some point, it became clear that fibrillary glomerulopathies really should be probably called GN with organized deposits. And you could break it down this way. And the fibrillary GN is its own diagnosis that's now defined by DNA JB9. So this is kind of the better way to look at these things now. You start with a Congo red. If it's positive, you've got amyloid, you decide is it ALA, AA or something, or et cetera. And then the non-amyloid, we've seen diabetic fibrillosis, which is non-immune mediated. Fibronectin is another one. But once you get to immunoglobulin derived, this is where we really are now. And so ITG is very different than fibrillary GN. And you've got cryoglobulinemic and lupus, et cetera. And also, that's good enough for this. But I think that's the problem for so many years. There was so much debate about, what is ITG versus fibrillary GN. And I think now with the distinction that it's got this very specific pathophysiology, or at least pathophysiologic staining, that it's its own disease. This is in 1996, before we knew about DNA JB9. This was over 100 patients that Helmut Reinke put in NDT, and this kind of fits our patient, middle-aged, hematuria in 70%, proteinuria in 100%, nephrotic range in 75%. Ours is a little unusual because it's crescentic. Elevated creatinine 50% at diagnosis, hypertension 70%, bad prognosis with it will go into end-stage renal in 4 years. That's pretty rapid. Recurs in the transplant a third of the time. The smudgy deposits on IF, this was recognized fairly early. And that these non-organized fibrils was very important, and they were around 20 nanometers, but can vary a little bit. What's interesting is more recently, this HLA-DR7 has been found in 50% of the patients, where it's only in 25% of control. So who knows what that really means? But it's had a long association, though. The problem is there's a lot of things: hepatitis C, malignancy. But in a lot of these cases, the history of malignancy was over 15 years before the diagnosis of FGN. So I'm not sure if that's really related or not. Occasionally a monoclonal gammopathy, and then there's a whole host of other things that have been described. Who knows if they're related or just two things together. So then it wasn't until, the last, 5 years or so that it actually got figured out what this is all about. And that this was done at the Mayo Clinic, where a lot of this work has been done, where they started staining for DNA JB9. And here you can see it in February GN. See all these glomeruli lighting up and very strong staining here. And here it's negative in a normal individual, and it was negative in light chain amyloid, which seems silly now, but at the time they kind of had to prove that it was unique to this one condition. And here's some of the findings. It's all over the place again, with all the different things that these patients can have: autoimmune disease, diabetes. Who knows what all this means? But it's it has a lot of presentations, but it's not a common GN, so it's not something that we generally think about, or that I would think about early in this when evaluating a patient.
Roger,
Yes, Mario.
can you please go back to that slide? I just want to point out something that Helmut makes a strong point about. The next one. Next one.
This one?
No, the next one forward. That one.
Sorry.
Is the preponderance of females over males. And Helmut makes a huge point about that. If you have a woman with severe hypertension, then this is part of the differential, as long as everything else comes into context.
Yeah, thanks, Mario. I missed that. So what is DNA JB9? I'm not going to pretend like I know what it is, but I think you have to be a real cell physiologist to understand this, but it's a 223 amino acid protein of the DNA J family of chaperones. These are proteins that influence cellular processes by regulating heat shock proteins. And so it's localized to endoplasmic reticulum, and it is induced by the reticulum stress. So any stress is going on, and its final role is to protect stress cells from apoptosis or dying. So I'm not going to try to pretend like I know any more than that, but what it's doing in the glomeruli in these patients is really unknown. Realize it's in the glomerulus, but there's also antibodies in the glomerulus, which has some influence of why we think what we might treat. This is nice also from the Mayo Clinic, where they found that the serum levels of DNA GB9 were elevated in patients with fibrillary GN. Here's the fibrillary GN, but it's not like it's negative completely in other people in their blood. These are normal controls. This is multiple myeloma. This is non-fibrillary GN related glomerular disease here, and this is AL amyloid. So there is somewhat of a distinction, but there's also a little bit of overlap here. So it's not like you can make the diagnosis. But using this, they thought that maybe that's even a marker for disease response. So what about treatment? Well, like everything else in nephrology, we give immunosuppressive agents because we don't know what else to do. And there are antibodies there, so it makes a lot of sense. The evidence for prednisone doing something is pretty non-existent. Cyclophosphamide is pretty non-existent. And we're really left with, of course, rituximab, which is where we always fall back on in the end. And so there's been case reports of rituximab being effective for fibrillary GN. The problem, of course, is when you have a case here and a case there, you're always worried about reporting bias, that you're only going to report the ones that work. Here's a kind of a collection of some of the studies. None of these have many people. The biggest one here is one of 12. But, here we have 3 non-progression outcome. And if that does if it slows progression, that's significant, since ESRD, it happens in 4 years. ESRD 1, no response in 2, only complete response in 1, partial response in 4, no response in 1, ESRD in the other. Of 12 non-progressors are 4, 5 progressed to ESRD, and 3 were progressed but not to ESRD. So even with rituximab, it's unclear if this is doing anything for the patients with this disease. But it's something I think that it's right now. I don't know that we have a lot more to offer. This came out in 2020. It's a treatment of fibrillary GN with rituximab, again out of Mayo Clinic, a 12-month pilot study. They had 11 patients, non-controlled, and the primary outcome was preservation of kidney function and creatinine clearance and proteinuria. And you can see it really, they gave rituximab 2 grams, and 6 months later they gave another 2 grams 2 weeks apart. And none of them had complete remission. Only about a fourth of them had a partial remission. And there was no change in the DNA JB9 levels. Or at least no significant change. So it really is not a very exciting therapy. So what about fibrillary glomerulonephritis? Steve made the point that fibrillary GN can have just about every presentation. I was able to find this paper. It was in the Indian Journal of Nephrology, but it's out of Montefiore Medical Center, the Hofstra School of Medicine in New York, and it was a single case. But the value of it is it has a little table that looks at some of the crescentic, the history of crescentic GN and how it's been treated. But a very similar patient. 60-year-old patient presents with a creatinine of 17, was 1.24 months earlier. It's very similar to ours, except ours was 1.4, 2 weeks earlier. Secondary workup was negative. A biopsy showed 8 of 12 of the glomerular had crescents, some mild interstitial fibrosis. They tried cyclophosphamide and steroids, became and remained dialysis dependent, no surprise. But I think the value of this is in this table here, which the clinical features, renal outcome, and other cases of crescentic fibrillary GN. And if you look on the right here, you've got dialysis dependent. One patient did well and the other 5. So 1 out of whatever 6 or 7, 8 patients seemed to respond. Clearly not a very optimistic view. Here they're using MMF, cyclophosphamide, Plex, cyclophosphamide. This is old and it probably precedes enough data on rituximab. So I want to open it up before we end this. I want to open up to a last poll here. What would you do with this patient? I would tell you that he is he's now anuric and he's on dialysis. Would you give him steroids and rituximab? Would you give him steroids and cyclophosphamide, or would you give him nothing? (15 of 16 glomeruli have circumferential crescents. He's anuric. For
those days was like 10%, 20%.
But his fibrosis was 10 to 20%. So is that 10 to 20% because it's so rapid it hasn't had time, or does that mean a good prognosis? I would interpret with those glomeruli that with circumferential crescents that's just a matter of time before that number gets much larger. But on the other hand, it's what do you think? Do you want to give this guy a chance? We've got 20% say steroids and cyclophosphamide. Our term has always been no regret Cytoxan. Hit it with everything you can. The other is 44% say steroids and rituximab, and 36% say no immunosuppression. I'll tell you what was done, and this is a second opinion. He'd already received 1 dose of rituximab and was about to receive his 2nd dose and wanted my opinion. And my opinion was, I don't think you're going to get better, but I don't see any harm. Go ahead, give it your best shot. Go with rituximab. I'm not going to change the cyclophosphamide at this point and see what happens. He has not gotten any better. I don't think it was wrong. I don't think any of these answers are wrong, but I think it'd be extremely unlikely that this patient could possibly get better. Because clinically, he acted like anti-GBM disease. He had RPGN with rapid AKI and became anuric. And although there was a little bit of ATN, I don't really think there was any hope. And when patients with anti-GBM disease have this clinical presentation, there's almost no hope of them getting better. Dick, what did you vote for? Treatment or no treatment?
Steroids and cyclophosphamide I voted for, largely because of the very rapidity with which this disease has developed, the extreme hypercellularity of the lesion on the biopsy. I don't know of any data at all when to declare futility in fibrillary GN with crescents. We have some data in anti-GBM disease and in ANCA disease, and I must say, even that data doesn't help me very much to make a futility decision. That is, when to completely give up. In a young person, for example, with anti-GBM disease who's on dialysis and has 100% crescents, I would still treat them because I don't know when to give up. Now, this guy is a little older, but the biopsy looks like he's got a recoverable lesion, so I would give him the benefit of the doubt. Why would I choose cyclophosphamide? Just because it seems to be more efficacious in extensive crescent disease. We have more data on it than with rituximab.
I think it's because you're the no regret Cytoxin camp, which we've always liked, which.
Roger,
Yes, Mario.
have a question for you. I was not aware of this. So there is an antibody now that we can measure against DNA JB9?
No.
Because one of the slides you mentioned a titer.
No, actually, I don't know, Mario. I assume this is.
There. DNA JB9 levels. What's that?
I think it's a circulating level, I believe, in the blood, and it's experimental. But
so what is that? Is that an antibody? What is it?
no, I think it's the protein they're measuring. That's just circulating. But I don't think it's the antibody. I think it's a circulating level of the protein. That it's higher. It's just weird, oddly, unfolding protein that
no, I
apparently we all
understand.
have.
I just never heard of DNA JB9 levels. I heard.
Yeah, I think it's only experimental, and hopefully they thought it would correlate with response, but it's hard to say here because nobody responded. So
yeah. All right. Thank you.
Yeah, absolutely. So yeah, I don't know. It's a good point, Dick. I like the idea of, we don't know, give it the benefit of the doubt within reason. I mean, if this is a 90-year-old, I'm sure you'd have a different approach.
Right.
But he's a pretty healthy guy, and I think that's reasonable. And that was their approach. I don't know that I would have changed over to cyclophosphamide at this point, but I would just continue the rituximab. He'd gotten pulsed and everything, but I think they're both reasonable response. I think they're all reasonable answers. Anybody want to defend their answer?
Roger?
Yes.
In the cases that you saw, in those that had responded, so not this guy, he hasn't responded yet, at least. Is there a role for maintenance, or do you treat it like good pastures where you're done?
I don't know the answer to that, Bill. I didn't.
Well, I think if this patient did respond and recovered some useful renal function, I don't know whether maintenance therapy with what? Rituximab? You can't maintain patients with cyclophosphamide.
Right.
It's only useful for a short period of time, and you never give it as a maintenance therapy.
Sure.
So
yeah, I think it's either rituximab or MMF, and I think it's
right.
It's a good question, Bill. I mean, I think I would probably, if I thought the patient really responded, I would give rituximab for a while, and then when it got rejected, maybe go to MMF. I mean, but there is no data on that as far as I know, and I didn't really look into it more extensively. The long-term outcome of patients that do respond. I mean, you brought up the point, maybe there's a second hit. You people have fibrillar IgN, and a lot of times with a second hit, you get over a second hit, you're back to your kind of baseline, you may not need much. So I don't know. It's a really good point.
Well, it just seems so much like good pastures, and I just, I know it's not, but it just that struck me because good pastures is one of those that usually that does not need maintenance.
Yeah, good. Yeah, I don't know that I'd feel that's comfortable, but I don't know that we'll ever know. This is not a common disease.
Well, there are differences between rituximab and cyclophosphamide. Cyclophosphamide is anti-proliferative. Rituximab has no effect on proliferation of mesangial cells or podocytes. It's strictly an anti-CD20. Cyclophosphamide and rituximab do share the fact that they affect CD20, but cyclophosphamide is much more effective in plasma cell derived immunoglobulin than immunoglobulins from pre-B cell. So if you are considering a chronic disease that may be plasma cell derived, think cyclophosphamide, not rituximab. Now, rituximab is useful in anti-GBM disease because it's an acute self-limited disease. And if you control the antibody production, you can get a cure, but not in this condition.
So what would you say about MMF, given your those? Where does MMF fit into this?
Yeah, I don't know.
No, but immunologically, where does MMF fit in?
Well, MMF is anti-proliferative as well, and maybe anti-inflammatory in some patients.
Yeah, I mean,
I can't tell you a good rationale, Roger, for deciding cyclophosphamide versus rituximab on the basis of an N=1 experiment. And that's what it would be.
Yeah. Well, unfortunately, he's not doing well. Unfortunately, he feels great on dialysis, actually. He has no side effects. And although remember, he has a plain fibrillary GN. I don't know about crescentic fibrillary GN, but he's got a 30% chance of recurrence in his allograft. And who knows if that would influence your immunosuppression. We'll have to see. Based on, and who knows if you if you also let it burn out, like you kind of do with some of these other diseases before you transplant. These are all unanswered questions. I wouldn't rush into it too much, but I don't think you have to wait forever. It's really unknown, and hopefully this guy will do okay. It's a devastating disease, but at least it was limited to his kidneys, unlike a systemic vasculitis or lupus,
Right.
which might have destroyed other organs.
Right.
I'm going to wrap this up. Thank you, everybody. We will be off the next 2 weeks. We're going to be out of town, out of the country, but we'll be back. I already know our next 2 cases, which will start in 3 weeks. Are going to be great cases. So till then, we'll see everybody, and thanks for everybody's comments.
Thanks, Roger. Great case. Thank
Thanks,
you.
Dick.